Bismillah, wassalatu wassalamu ala rasulillah. Thank you for having me, and I hope to add something for you regarding the pharmacist point of view for regarding the septic shock and sepsis management. A brief definition about sepsis and septic shock: the syndrome caused by the host response to an infection, and severity sepsis is defined as sepsis with associated organ dysfunction, and septic shock is severe sepsis with hemodynamic instability. The guideline 2021 guideline recommend that against using Quicksilver compared to SARS News or News as a single screening tool for sepsis or septic shock, as Dr. Kamran said. The management of sepsis or septic shock have so many different elements, but the antimicrobial therapy is an essential component of the overall management and should be ideally targeted based on the underlying cause of sepsis. Before starting any management regarding the antibiotic, we have to order appropriate culture before starting antibiotic, blood culture before antibiotics, and obtain culture from other suspected site of infection. Antibiotics should be given as quickly as possible after sepsis is recognized, and recommendation said that the antibiotic initiation must be within 1 hour. For each 1 hour, that antibiotic administration was delayed, there was a 4% increase in risk adjusted in hospital mortality. Also, initiation of appropriate antimicrobial within the first hour after onset of septic shock was associated with almost 80% survival to hospital discharge. So which kind of antibiotic we have to use in septic shock? For adult with sepsis or septic shock at high risk of methicillin resistant staph aureus, we recommend using empiric antimicrobial with MRSA coverage over using antimicrobial without MRSA coverage. And in case of MDR or multi-drug resistance, we just using two antimicrobial together with gram-negative coverage for empiric treatment over only one gram-negative agent. Regarding which antibiotic we have to use for a specific patient, there are many factors impact on the antibiotic pharmacokinetic for sepsis patient. As we know, as a result of sepsis, the drug absorption and distribution and elimination will be affected due to hepatic impairment or renal impairment or increase in body fluid balance. And regarding the AKI, the renal impairment will decrease the elimination of a drug which is excreted through the kidney. And also, if the liver function changed, all the medication which are metabolized by the liver will be affected, either increasing in the effect or decreasing the effect. Hypoalbuminemia lead to increased volume distribution and free drug, and consequently increases the elimination. We recommend IV administration during acute phase of sepsis or septic shock. There is the recommendation from the guideline for adults with sepsis or septic shock. We recommend optimizing dosing strategies of antimicrobial based on accepted pharmacokinetic, pharmacodynamic principles and specific during drug properties. This table shows the physiochemical and pharmacokinetic characteristics of commonly used antibiotics during sepsis. And I will just only focus on gentamicin and vancomycin, and they are both renally excreted and they are hydrophilic. So if the patient having any problem with the renal function, and this medication will be affected, and all the side effect will be increased opportunity to having the side effect of gentamicin and vancomycin, including nephrotoxicity and ototoxicity. So how to achieve the optimum dosing of antibiotic effect? We have the TDM, therapeutic drug monitoring, especially for aminoglycoside and glycopeptide, vancomycin and gentamicin. What we have to do, we have to measure the level of the gentamicin or vancomycin. For gentamicin, we have to take a blood sample as a peak and between 6 to 14 hours. And for the vancomycin, we have to take a sample as a trough level. A trough level, that means before giving the next dose of vancomycin. Beta-lactams are commonly used in sepsis or septic shock, given their broad spectrum of activity and wide therapeutic index. As time-dependent antimicrobial, they exhibit improved pharmacokinetic pharmacodynamic profile when the concentration is maintained above the threshold for a longer duration. That's why the recommendation comes to suggest using prolonged infusion of beta-lactam for maintenance after an initial bolus over conventional bolus infusion. In case of patient with renal impairment, what we have to do with sepsis, of course, we have to initiate the antimicrobial treatment with wide therapeutic index beta-lactams and deferring dose adjustment until more than 48 hours or 2 days when renal function is better characterized. Given the importance of achieving optimal antimicrobial therapy within the first 48 hours in sepsis or septic shock, premature renal dose adjustment of antimicrobial may increase the risk of suboptimal concentration and poor outcome. So we have to start the beta-lactams and wait for 48 hours and start again to assess the patient need. Thank you very much. Any questions, guys? Sure.